Hello, everyone. I can't see. Can you hear me? Yes? Can everybody take their seats, please? We're going to start the session. Good morning again, everyone. Thank you for joining us. So just as a reminder, we are in a hybrid conference. And for those of you who are here, please wear your mask. And for the virtual presenters will be on a virtual. And we also like to remind you, you can send your questions through the chat. So it's my honor and pleasure to co-moderate the session. I'm Aida Haptizion.
Jody Barkin, nice to see everyone.
So we'll start this session, early clinical evaluation, and we have three fantastic speakers. We'll start with the first one, Professor David Whitcomb, who is the Giant Eagle Foundation Professor of Cancer Genetics, who doesn't need really an introduction, but he's from the University of Pittsburgh. And his session is entitled Assessment and Biomarkers of Severe Pancreatitis.
Well, good morning, everyone. What I'd like to do is just spend a few minutes quickly blowing up everything you've learned about acute pancreatitis and resetting your minds for the future. I'd like to start with the conclusions. The first one is that acute pancreatitis is an evolving inflammatory process. And so what you measure at one time point may not be the same as you measure later. Secondly, all the major complications are linked to pathologic vascular response to injury or inflammation, especially linked with the capillary leak syndrome. Third, the first 6 hours are critical for proper classification and initiation of treatment for patients. And in trauma, this is called the golden hour, because what is known is that what you do in the first several hours after an injury has profound implications for outcome. And the same is true with acute pancreatitis. The revised Atlanta criteria are not reliable in early disease assessment. That Sears precedes multi-organ failure in most cases, but it has a very poor positive predictive value, and it doesn't precede it in all cases. The modified Marshall score, which is within the revised Atlanta criteria, should not be used to classify patients within the first 24 to 48 hours. And new tools are needed to rapidly and correctly classify acute pancreatitis patients by etiology and by the likelihood of organ failure. Now, I would like to go over the things that led me to these conclusions. The first one is we know that death in acute pancreatitis is usually linked to systemic inflammation. And we use a clinical syndrome called Sears that has been talked about before. You need to have two or more of the following, but in acute pancreatitis, of course, the temperature is rarely abnormal. And the others are physiologic measures that often you can generate just by running around the block. Sears is also seen in sepsis, multiple trauma, burns, and the COVID-19 disease, suggesting it doesn't originate from the pancreas itself, and the factors leading to multi-organ failure are not dependent on pancreas-specific agents. Now, one of the most important observations by Emery's group in Glasgow was that organ failure usually requires persistent Sears for about 24 to 48 hours. And if you still have Sears after 48 hours, then you're likely to have severe acute pancreatitis. So let's review the dynamic process. In general, you have injury, a pro-inflammatory response, an anti-inflammatory response, such as CARS, and then resolution. The factors associated with severity are major damage to the pancreas and pancreatic necrosis, the cytokine storm, Sears, which is sepsis physiology, a capillary leak syndrome, and multi-organ failure. So it begins with anything that injures the pancreas, leading to trypsin activation. The trypsin causes tissue damage, and the tissue damage initiates a local inflammatory response in 3 phases: early, middle, and late. The early phase is the pro-inflammatory phase, and it actually causes additional tissue damage and is a feed-forward system. Fortunately, the immune system is self-regulating, and you begin to have anti-inflammatory counter-response to modulate the severity of the inflammatory response. And finally, this begins to dominate, and you shut off the severe acute pancreatitis, the inflammatory part. In some cases, however, you have a very severe pro-inflammatory response, and this spills outside of the pancreas and triggers the systemic inflammatory response, and in some cases goes on to the capillary leak syndrome, but in other cases does not. The capillary leak syndrome is associated with a pulmonary edema and with hypotension from loss of fluid from the vascular compartment, leading to shock. And the hypovolemia, especially in the visceral organs, leads to pancreatic necrosis, acute kidney injury, and gut ileus with leakage of bacterial products into the lymphatics, which go back to the circulation and drive continued Sears and further aggravates the capillary leak syndrome. Now, the only thing we have that can really change this is giving fluids early to treat the hypotension, and enteral nutrition to strengthen the intestinal cells and stop the bacterial translocation. Now, the time frame here is pretty rapid, and you get to the systemic inflammatory response, within 6 to 12 hours. And after that, the horse is out of the barn, and it's a little bit late, and you have to use supportive care rather than really actually preventing further damage that you can do during the golden hour. So I'd like to look at the transition between Sears and the capillary leak syndrome. And this is a study that we did in Pittsburgh, and actually Marcus Lurch's group helped do a validation. And we looked at an interesting peptide called angiopoietin-2. This is an autocrine hormone that's released from endothelial cells during injury that feeds back on itself through the Tie2 receptor and blocks another hormone called angiopoietin-1. And the endothelial cells go under stress. They pull apart, and the tight junctions open up, and proteins and fluid and other things can come out into a local area of injury. And that's what you see with local swelling and inflammation. But if this becomes systemic, then it suggests that the whole body is becoming leaky through a physiologic process going awry. And what we found is those patients that were in multi-organ failure had very high levels of angiopoietin-2 early, but it very rapidly, or it trended down over the first 7 days of pancreatitis. But those patients with Sears, but without organ failure, did not have activation of the endothelial cells and a rise of the angiopoietin-2. Now, the mechanism of multi-organ failure is very interesting, because we wanted to know, is this regulated or is this an injury to the endothelial cells, so they actually were poisoned or toxic and broke down? Because if it was regulated, you'd lose albumin. If they were actually injured in endothelial cell damage, then the large proteins would come through as well. And we asked the question of whether or not this was important. So we built a mathematical model, a compartment model, in order to organize information from clinical patients. And it's a really simple model. You have the heart on the top. It goes down through a capillary bed and back up into the heart. There is a pre-capillary area where there's high pressure that can push molecules out through fenestrated capillaries. And on the post-capillary side, there's low pressure but high oncotic pressure from albumin and the large proteins, the non-albumin plasma proteins, to draw fluid back into the vascular compartment and then return to the heart. If the albumin leaks out, it goes through the lymphatics and returns to the heart, and the other organs such as the pancreas, kidney, and lung are linked to it. If you add another capillary leak that's large, you upset the apple cart, and what happens is that both the small and large proteins rapidly would come out. You lose your post-capillary oncotic pressure. The fluid goes into interstitial and third spaces, and you end up with venous hypovolemia causing shock and these consequences. So we tested this model using a series of patients. We measured pre-injury information about hematocrit and albumin and total protein and creatinine so that we could look what happened dynamically, because the range of these values in the general population is all over the place. So we used each patient as their own control. We did trajectory analysis on them. We had patients with severe acute pancreatitis by Sears. Some of them had multi-organ failure and the others did not. What we found is hemoconcentration was very interesting, because compared to pre-admission level, an increase of 5 was seen in the severe acute pancreatitis, but in the non-severe, it did not rise. And in general, hematocrit greater than 3 distinguished multi-organ failure from non-organ failure. But if you look at the cutoff values from a population, they were worthless. Biomarkers, it turns out that if you look at the BUN and creatinine in severe in red versus normal, both the BUN and creatinine are raising at the same trajectory, which means they're having pre-renal azotemia. When we look at the albumin and the total protein and the non-albumin protein, we see that there is a slight decrease in albumin in patients with Sears, but if you have multi-organ failure, there's a precipitous drop. But more importantly, you lose the large proteins. And in fact, if you look at the change of the large proteins versus the small ones within the first 24 hours, the large proteins increase in concentration because you've lost the smaller ones. And then as the endothelial cells break down, you precipitously lose the large molecules, suggesting you have a time period of about 24 hours to intervene to prevent this destruction. So the criteria we came up with is that if you rise from baseline, the hematocrit, it's important. If you see an increase in BUN and creatinine from baseline in parallel, it's pre-renal azotemia and your patient is intravascularly depleted. And an early drop in albumin with an increase in non-albumin protein is associated with severity, but then you see a drop in the non-albumin plasma protein. So the revised Atlanta criteria, we're familiar with them. The interstitial and necrotizing pancreatitis, we're talking about the latter, but organ failure is associated with respiratory, cardiovascular, and renal. And there's mild, moderate, which is organ failure that gets better, and severe, where organ failure does not get better, it's persistent. The key is the Marshall score, and you see that there is respiratory, renal, and cardiovascular, but the severity you have to have is so severe that it's too late in the game and it takes a while for each of these to increase. We know that the Sears is a very poor positive predictive value, which is used in the Ranson score, that the multiple organ failure can occur without Sears, especially in hypertriglyceridemic acute pancreatitis, that the modified Marshall score for pulmonary is too severe and you miss early dysfunction, that the modified score for cardiovascular is also too severe, a blood pressure less than 90 that's not responsive to fluid, and if you give early fluid, it masks a severe process going on, causing the patient to be mistriaged. And renal failure, it takes a couple days for the BUN and creatinine to rise. So these factors make this scoring system irrelevant in early assessment of disease. For future direction, Dr. Papachristou and I and some others with the PROOF study found 5 biomarkers that mark different types of systems that is highly effective, but they're not available. You can't get them unless you do a research study. So we developed the ADAPT tool, which is on the iPhone, and it uses available criteria, and you can use it anywhere, and any person can use it around the world. It uses stuff that you can get at any emergency room, the vital signs, Chem7, LFT, CBC, and a few other things. And what we have shown is here's a case where we used it, and what it does is takes whatever information is available, goes through a whole series of severity calculators, and here it predicted that this patient, which by modified Marshall score was a mild to moderate, was actually developing severe acute pancreatitis. And the Mauser rules, which is a 95% confidence interval, suggested under 2 criteria, this patient had a 95% chance of getting organ failure. They were seen on the next morning on the GI rounds. The patient was recognized by the attending to be in trouble. They immediately bolused her with liters of fluid, moved her to the intensive care unit. She went into respiratory failure, was on a ventilator, and was in the hospital for a month. And if it hadn't been for a GI faculty member to recognize that the Marshall score was wrong and they were misclassified, the patient would be dead. So we believe that this is a very important observation. We think we need to reimagine our approach to focusing on the early time points, not using the revised Atlantic criteria, which is important for historical purposes, but will not lead us into the future.
Thank you, Dr. Whitcomb. We're going to take questions at the end.
Okay.
Thank you.
Our next speaker is Dr. Thomas Ballen, who joins us from St. Antonius Hospital in Utrecht in the Netherlands. He'll be joining us virtually today, and he is an expert radiologist and part of the Dutch group. We'll play his video now, and then we'll join for questions again at the end. Thank you.
I will give this talk on the imaging diagnosis of pancreatitis virtually. I have nothing to disclose. The diagnosis of acute pancreatitis is made when give this talk on the imaging diagnosis of pancreatitis virtually. Abdominal pain, serum amylase or lipase more than 3 times the upper limit of normal, or the characteristic imaging findings of acute pancreatitis. And I will discuss these with you. There are various imaging modalities available for the non-invasive acute pancreatitis assessment. Ultrasound is mainly used for the detection of gallstones. We rarely use it for the diagnosis of acute pancreatitis. And CT and MRI. MRI is as good as CT in diagnosing acute pancreatitis. With the additional MRCP sequence, we can detect gallstones and common bile ducts even better than on CT. And MRI is superior to CT for the characterization of collections. But MRI is not always available, and CT is readily available in most instances throughout the whole world. So CT remains the workhorse of pancreatitis evaluation in acute pancreatitis. Here, an example of a patient who had a wall of necrosis collection, seemingly homogeneous, looking on CT, but clearly heterogeneous on MRI. So MRI has a true complementary role in the assessment of acute pancreatitis. So CT remains the first-line imaging modality of choice. It provides you the diagnosis and alternative diagnosis. We can assess the severity of acute pancreatitis. Also, the evaluation of complications during the course of acute pancreatitis is better on CT than on MRI, and we can use CT for CT-guided intervention. There are some disadvantages. CT is poor in detecting gallstones. CT has a limited ability to characterize the internal contents of collections. There are some pitfalls in the diagnosis of pancreatic necrosis and extrapancreatic necrosis, and I will go over these. There is this issue of radiation dose, especially in younger patients, and we have to give contrast material, which is relatively contraindicated in patients with contrast allergy and renal failure. So what are the imaging features of acute pancreatitis? We can discriminate pancreatic changes and peripancreatic changes. Pancreatic changes is a swollen pancreas, which can be a sign of interstitial pancreatitis. And we can see non-enhancement areas, which is typical for necrotizing pancreatitis, where IV contrast is mandatory to provide you the diagnosis. The peripancreatic features include fat stranding and collections. And the extrapancreatic features in acute pancreatitis are pleural effusion, ascites, and also vascular complications. So the imaging semiology of findings on CT are based on the revised Atlanta classification in 2012. There are two morphologic types, the interstitial and necrotizing types of pancreatitis, and I will go over these in detail. I will not go in detail about the associated collections which are defined in the revised Atlanta criteria. So in this case, with contrast enhanced CT, we see a normal enhancing pancreatic parenchyma and some fluid here in the left retroperitoneal space. So this is a classic case of interstitial pancreatitis with an acute pancreatic fluid collection. And we did a follow-up CT and these fluid collection resolved spontaneously. Here another example of interstitial pancreatitis and normal enhancing pancreatic parenchyma surrounded by some fat stranding, a classic case of interstitial pancreatitis. So when we go over necrotizing pancreatitis, we can discriminate between three subtypes. We have pancreatic necrosis only. So this is a very rare occurrence in acute pancreatitis. So we don't see any extra pancreatic fluid collection in this case only here in this area of necrosis, a non-perfused area in the neck and body of the pancreas. The most common type of necrotizing pancreatitis is the combined necrosis of pancreatic parenchyma and extrapancreatic tissue, as in this case, non-enhancement of the neck of the pancreas and part of the body, but also necrotic areas in the left retroperitoneal space. In this patient who had also a partial thrombus in the portal vein.
Apologies, everyone. We obviously think that there's been some technical difficulties with the recording. We're reaching out right now to Dr. Ballen to get a copy of his slides and hopefully be able to correct this shortly. In the meantime, we'll switch to our next speaker.
I'll introduce our next speaker and apologize again, but we'll move to our third speaker, who's Professor Vikash Singh from Johns Hopkins University School of Medicine. He's the Director of Pancreatology and Associate Professor of Medicine, and his session is entitled Relation of Early Severity and Necrotizing Pancreatitis. Thank you.
Thank you very much. I'd like to thank the APA organizers for giving me the opportunity to speak to you today. And I have to say it's very refreshing that we can all be in person. So thanks for that as well. I have no relevant conflicts of interest. I would like to say if pancreatitis was McDonald's, disease severity would be our hamburger. Just a PubMed search for severe acute pancreatitis this morning resulted in almost 15,000 entries on this topic since 1920. So one of the perennial questions that largely began as a debate about 10 years ago was really, what has a greater impact on mortality? Is it persistent organ failure or infected necrosis? There was a systematic review conducted by Max Petrov and John Windsor that was published around that time that evaluated 14 studies that had been published between 1993 and 2009 with a total of almost 1,500 patients with necrotizing pancreatitis. What was interesting is that among the patients with organ failure, there was about a 30% mortality. And then among the patients with infected necrosis, there was a mortality of about 32%. One of the conclusions that the authors had raised was that in these patients with acute pancreatitis, the absolute influence of organ failure and infected pancreatic necrosis on mortality is comparable. And thus the presence of either indicates severe disease. The relative risk of mortality doubles when organ failure and infected pancreatic necrosis are both present, and indicates extremely severe or critical acute pancreatitis. And then this largely then set up the debate between the two different severity classification scoring systems. The first, of course, is the revised Atlanta criteria, which defines severe acute pancreatitis as the presence of persistent organ failure. And this was in contrast to a similar but a surgically derived a classification system known as a determinant-based classification that was published around the same time that defines severe acute pancreatitis as a presence of infected necrosis or persistent organ failure. And they defined critical acute pancreatitis as the presence of both infected necrosis and persistent organ failure. However, we've learned a couple of things since this study that was now almost 10 years ago. The first is that persistent organ failure and multi-system persistent organ failure have a greater impact on mortality than infected necrosis. There have at least been studies starting in around the same time, published by the Dutch group in 2009, and then a subsequent Chinese study in 2014 showed a large adjusted odds ratio for mortality in their multivariable analyses in those patients with persistent organ failure, ranging anywhere from 17 to 18. More recent studies have also added to this data by showing that multi-system persistent organ failure is associated with higher mortality than single-system persistent organ failure and necrotizing pancreatitis. There have now been 2 studies. One is by the Dutch Acute Pancreatitis Study Group and was published in 2019. And then another large study by another Singh, not this Singh, but from PGI Chandigarh that was just published this year, looking at the impact of single and multi-system persistent organ failure. As you can see, the mortality attributed to single persistent organ failure was much lower than that of multi-system persistent organ failure, where it was almost 2 to 3 times higher. And then when all 3 systems were affected in the Marshall organ failure scoring system, you can see that the mortality skyrocketed up into the 60 to 75% range. The next point I wanted to make is that infected pancreatic necrosis is associated with no to low mortality in the absence of persistent organ failure. One of the studies that I had first done looking at our MOSAP database at Brigham and Women's Hospital when I was a fellow, we had gone back and actually looked at all of the 338 patients that we had prospectively collected over the 2 years that I had actually been involved in this database. But what we found was that in those patients who didn't have any organ failure, there was no mortality. And those patients who had transient organ failure, there was relatively lower mortality, around 7.5%. But among those with persistent organ failure, you can see the mortality went up to around 26%. And when you looked at those patients with sterile and infected necrosis, if they had no organ failure, they didn't die. If they had transient organ failure, they didn't die. But if they had persistent organ failure, you can see their mortality was as high as 50%. And this, of course, was also modified by having the presence of multi-system organ failure. There have also been 2 other studies. One was by the Dutch group, which showed that those patients with infected pancreatic necrosis who didn't have any organ failure, their mortality was 4%. And just a year before that, our colleagues at the All India Institute of Medical Sciences in Delhi showed that among those patients with infected pancreatic necrosis, if organ failure was absent, the mortality was only 4%. The third point I wanted to make is that early versus late infected pancreatic necrosis is associated with higher mortality due to coincident organ failure, but the type of interventions pursued matter. So this was a Chinese study that was published about 6 years ago, and they looked at a cohort of patients with both early and late infected necrosis that was based on the time of diagnosis. So in those patients with early, they had a diagnosis of infected necrosis within a month, whereas those patients with late infected necrosis were those who had a diagnosis after a month. And they had about 134 patients in the early group and 38 patients in the late group. And as you can see here, there weren't really big differences between these groups. There was a little bit more organ failure in those patients with early infected necrosis in this cohort. However, the rates of open surgical necrosectomy, primary percutaneous drainage were similar. However, look at the mortality. Those patients with early infected necrosis had nearly 1 in 5 of them passed, whereas those with late infected necrosis, only 3% passed, which is very similar to the other 2 studies where the mortality was 4%. So what are the reasons for this? The Dutch group nicely showed in assessing organic failure on a dynamic spectrum that actually the prevalence of organ failure in these patients with acute necrotizing pancreatitis begins to decline after 1 month. And interestingly, we know that about half of infected pancreatic necrosis cases are in fact diagnosed in the first 30 days. So that means the other half are actually coming after that 1 month time period when actually the overall prevalence of organ failure has declined in these patients. So I think that's an important point. The other thing I wanted to mention, and this is data that we've submitted for review based on 743 patients with culture confirmed infected pancreatic necrosis, not suspected, but culture confirmed across 19 centers on 3 continents. This was done by Rob Moran when he was a fellow with me. But what you can see here, and I think it's important to point out that not surprisingly, persistent organ failure and infected pancreatic necrosis are both associated with high mortality, high and significant mortality. But look at the impact of enteral nutrition. In fact, those patients who were on enteral nutrition had a significantly reduced chance of dying, whereas those who underwent early open surgical necrosectomy had an increased risk of dying, whereas all the other interventions, including minimally invasive surgery and percutaneous drainage, had no impact on mortality. So it's not just the characteristics of the patient with regards to the presence of organ failure and infected necrosis, but also what we do to them. Do we start the enteral nutrition? Do we pursue early surgery or not? The next point I wanted to make is that the duration, but not the onset of persistent organ failure, has a stronger impact on mortality and necrotizing pancreatitis. There have now been several studies that have looked at the onset of persistent organ failure as whether it occurs in the first week or after the first week. And as you can see, there are relatively similar rates of organ failure in the first week, at least in these three studies. But a study coming from South Korea suggested that actually there was higher mortality in those patients who had organ failure occurring after the first week compared to the, after the first week compared to occurring within the first week. But what we've come to note in larger studies, both returning now again to the Dutch study and the study from All India Institute of Medical Sciences, you can see that up top is the onset of combined persistent organ failure based on when it occurred. So you anywhere from less than 48 hours all the way out to greater than 2 weeks. You can see that onset really didn't impact mortality much. All those numbers look relatively about the same. However, when you go down to the bottom and you look at the combined persistent organ failure rates in these two separate studies based on the total duration of persistent organ failure, you can see there appears to be a little heightened mortality early. That's probably those patients with fulminant organ failure. And then later on, when you go beyond 3 weeks, you start to see an increase in mortality again. So I think the duration has an impact, but not necessarily the onset of persistent organ failure in these patients with necrotizing pancreatitis. And that might have something to do with the fact that that new organ failure continues well beyond the first 2 weeks. And this was also from the Dutch study. And you can see from a dynamic perspective, when you look at new respiratory failure, new cardiovascular failure, and new renal failure, the patients continue to develop this well beyond the first 2 weeks in patients. And these patients, of course, all had necrotizing pancreatitis. The last point I wanted to make is our unrecognized entity, or the one that we probably miss often, is those patients who only have extrapancreatic necrosis. These form about 7% of all patients who have necrotizing pancreatitis. And often you don't realize this until they're kind of later in their hospital course, or they come to see you as outpatients. But it's important to identify these patients because you can at least prognosticate how they're going to do when they leave the hospital, or if they're going to leave the hospital, I should say. Because these patients have less persistent organ failure, infected necrosis, and mortality. And this has now been shown by several groups around the world when they have evaluated their cohorts of patients with extrapancreatic necrosis versus those who have combined parenchymal and extrapancreatic necrosis. And we certainly have to do a better job of picking this up. There tends to be even really high inter-observer variability for extrapancreatic necrosis in these patients. So these are my key points, exactly as stated. Persistent multi-system organ failure is a primary determinant of mortality in necrotizing pancreatitis. Infected pancreatic necrosis alone in the absence of persistent organ failure is associated with no or low mortality. Early infected necrosis is associated with a higher mortality than late infected necrosis, likely due to coincident organ failure, but interventions matter. The total duration, but not the onset of persistent organ failure, impacts mortality. And last but not least, extrapancreatic necrosis alone is associated with lower infected necrosis, persistent organ failure, and mortality than combined parenchymal and extrapancreatic necrosis. Thank you very much for your time.
Thank you again, Dr. Singh. We're going to open the panel discussion. So Dr. Whitcomb, are the slides working now? Yes? Okay. Apologize. So I guess we'll be back. So we'll go back to Dr. Ballen's presentation.
Hello everyone, I'm Ballen from the Netherlands. I will give this talk on the imaging diagnosis of pancreatitis virtually. I have nothing to disclose. The diagnosis of acute pancreatitis is made when two of the following three criteria are met. Abdominal pain, serum amylase or lipase more than 3 times the upper limit of normal, or the characteristic imaging findings of acute pancreatitis. And I will discuss these with you. There are various imaging modalities available for the non-invasive acute pancreatitis assessment. Ultrasound is mainly used for the detection of gallstones. We rarely use it for the diagnosis of acute pancreatitis. And CT and MRI. MRI is as good as CT in diagnosing acute pancreatitis. With the additional MRCP sequence, we can detect gallstones and common bile ducts even better than on CT. And MRI is superior to CT for the characterization of collections, but MRI is not always available, and CT is readily available in most instances throughout the whole world. So CT remains the workhorse of pancreatitis evaluation in acute pancreatitis. Here, an example of a patient who had a wall of necrosis collection, seemingly homogeneous looking on CT, but clearly heterogeneous on MRI. So MRI has a true complementary role in the assessment of acute pancreatitis. So CT remains the first-line imaging modality of choice. It provides you the diagnosis and alternative diagnosis. We can assess the severity of acute pancreatitis. Also, the evaluation of complications during the course of acute pancreatitis is better on CT than on MRI. And we can use CT for CT-guided intervention. There are some disadvantages. CT is poor in detecting gallstones. CT has a limited ability to characterize the internal contents of collections. There are some pitfalls in the diagnosis of pancreatic necrosis and extrapancreatic necrosis, and I will go over these. There is this issue of radiation dose, especially in younger patients. And we have to give contrast material, which is relatively contraindicated in patients with contrast allergy and renal failure. So what are the imaging features of acute pancreatitis? We can discriminate pancreatic changes and peripancreatic changes. Pancreatic changes is a swollen pancreas, which can be a sign of interstitial pancreatitis. And we can see non-enhancement areas, which is typical for necrotizing pancreatitis, where IV contrast is mandatory to provide you the diagnosis. The peripancreatic features include fat stranding and collections. And the extrapancreatic features in acute pancreatitis are pleural effusion, ascites, and also vascular complications. So the imaging semiology of findings on CT are based on the revised Atlanta classification in 2012. There are 2 morphologic types, the interstitial and necrotizing types of pancreatitis, and I will go over these in detail. I will not go in detail about the associated collections which are defined in the revised Atlanta criteria. So in this case, with contrast enhanced CT, we see a normal enhancing pancreatic parenchyma and some fluid here in the left retroperitoneal space. So this is a classic case of interstitial pancreatitis with an acute pancreatic fluid collection. And we did a follow-up CT, and these fluid collection resolved spontaneously. Here another example of interstitial pancreatitis and normal enhancing pancreatic parenchyma surrounded by some fat stranding, a classic case of interstitial pancreatitis. So when we go over necrotizing pancreatitis, we can discriminate between 3 subtypes. We have pancreatic necrosis only. So this is a very rare occurrence in acute pancreatitis. So we don't see any extrapancreatic fluid collection in this case, only here in this area of necrosis, a non-perfused area in the neck and body of the pancreas. The most common type of necrotizing pancreatitis is the combined necrosis of pancreatic parenchyma and extrapancreatic tissue, as in this case, non-enhancement of the neck of the pancreas and part of the body, but also necrotic areas in the left retroperitoneal space. In this patient who had also a partial thrombus in the portal vein. Here another example, non-perfused areas in the tail and body of the pancreas surrounded by acute necrotic collections in the left retroperitoneal space. Typical case of combined necrosis. So pancreatic necrosis, it is non-enhanced areas on CT, on MRI within the pancreas. It usually occurs within the first 4 days. It is typically associated with extrapancreatic necrosis, and CT may underestimate the presence and true extent of parenchyma necrosis when you perform it too early. So we perform it usually after day 4, and it is not always associated with poor prognosis. So what are the pitfalls? You can have a false negative case of necrotizing pancreatitis when you perform the CT too early. You can have a false positive case in case of reversible hypoperfusion of the pancreas. There can be overestimation of the extent of necrosis due to extrinsic compression. It's very hard to discern the exact nature of small foci of low density within the pancreas. It could be necrosis, fat or fluid or tissue edema. And it's also very hard to detect parenchymal necrosis in a pre-existent fatty pancreas. And also difficult to detect small foci of pancreatic necrosis, especially in the periphery of the pancreas. Here an example in this patient with a fatty pancreas at the start. So this patient got pancreatitis, and we see some edema and fluid-like or necrosis. We could not tell in the head of the pancreas. We did a follow-up CT, and here we see a normal enhancing pancreatic head. So there was no necrosis on the index CT. Another example of overestimation of extent of necrosis in this patient with a huge wall of necrosis and an area of necrotic parenchyma at the body of the tail. We percutaneously drained the wall of necrosis, and we see a lesser extent of necrosis, which we previously thought it was. So in this case, the extent of necrosis was overestimated. The last example in this case, the hyperperfused area here, we thought it was necrosis. We did a follow-up CT, but it turned out to be reversible hyperperfusion, so no necrosis. Last subtype is the extrapancreatic necrosis with a normal enhancing pancreatic parenchyma. See here in this case, normal enhancing pancreatic parenchyma surrounded by heterogeneous collections. Here in this case, patient with pleural effusion, ascites, and here normal enhancing pancreatic parenchyma surrounded by collections in the transverse mesocolon and the left retroperitoneal space. And we did a follow-up 2 weeks later. Now we see still a normal enhancing pancreatic parenchyma and a fully encapsulated walled-off necrosis collections in the transverse mesocolon and the left retroperitoneal space. So this is a classic case of extrapancreatic necrosis. So what is extrapancreatic necrosis? It is necrosis of peripancreatic fatty tissue by activated pancreatic enzymes. Pancreas has no capsule, so extrapancreatic necrosis can be progressive. At pathology, we see fat necrosis, extravasated pancreatic fluid and inflammatory and hemorrhagic components. And at CT, the key hallmark is heterogeneous collections with a preserved parenchymal enhancement. And the clinical cause depends on the occurrence of secondary infection. We did a study where we compared patients with extrapancreatic necrosis with parenchymal necrosis. So patients with extrapancreatic necrosis had less organ failure, less risk of infecting necrosis, and less mortality, unless the extrapancreatic necrosis got infected then we saw a similar mortality in these patients. So the clinical course heavily depends on the occurrence of secondary infection in these patients. What are the pitfalls? It is very difficult to diagnose extrapancreatic necrosis in the first week because extrapancreatic tissue does not enhance. In the later phase, we see heterogeneity. We see liquid and non-liquid density on CT. And the key is the location. Extrapancreatic necrosis occurs in areas harboring fat. So these are in the subperitoneal spaces of the transverse mesocolon and the ligaments, and also in the retroperitoneal spaces. Last example in this patient with normal enhancing pancreatics with little fluid at first, but then at follow-up, these collections got bigger, more in the transverse mesocolon and left retroperitoneal space. And 3 weeks later, these collections got even more bigger, and now we see gas bubbles, a sign of infected necrosis in this patient with extrapancreatic necrosis, with no necrosis of the pancreatic parenchyma. And with that, I would like to conclude that imaging has a major contributory role in the diagnosis and classification of acute pancreatitis. The workhorse in acute pancreatitis remains CT, but be aware of the limitations in the diagnosis of parenchyma necrosis and extrapancreatic necrosis, and also in the classification of peripancreatic collections. And here, MRI may be of a contributory role. And also, it is important for us to adhere to the revised Atlantic criteria terminology for the accurate communications between clinicians. And with that, I would like to thank you, the audience, for your attention, and goodbye.
Thank you to everyone for your patience and obviously being understanding in this new hybrid meeting world. We appreciate that technical difficulties will happen. And a major thanks to Margie, the APA staff and the AV staff for helping us to correct that situation. We'd like to ask the two additional panelists that are here to come up for our panel discussion, and Dr. Ballen will hopefully be able to join us virtually for this. For those of you joining online, if you have any questions, please feel free to put them in the chat and we will address them as part of this. For those of you joining online, if you have any questions, please feel free to put them in the chat and we will address them as part of this. For those of you joining online, if you have any questions, please feel free to put them in the chat and we will address them as part of this.
Thank you for an excellent session. I had a question for Dr. Singh. In your ISPAN study,
for those of you joining online, if you have any questions, please feel free to put them in the
you
chat.
had shown that there are results of
Thank you for an excellent session.
percutaneous
I had
interventions
a
or
question
drainage,
for
as well as
Dr.
minimally
Singh.
invasive and
In your
open
ISPAN
necrosectomy,
study,
those of you joining
but I
online,
didn't
if you
see
have any
data on the
questions, please feel free
endoscopic.
to put them in the
You
chat.
have
and we will
shown
address them as
that
part of
there are
this.
Comment on
results.
that.
Thank you for an
Yeah,
excellent
it's
session.
a good question.
I
All the
had a
patients in that
question
study were
for, as well as
recruited
minimally
between
invasive and- In your
2000
ISPAN
and
study, but I didn't see data on the
2016.
endoscopic.
And
You have
it
shown
was
that
primarily
there are
surgical
results.
patients
Thank you
who
for an
enrolled.
excellent session.
Endoscopy was just coming
I had a
online, and a
question
lot of the
for,
centers in
as well
Europe
as
and
minimally
Asia were
invasive.
not
In your
employing
ISPAN
endoscopic
study,
techniques for necrosis
data on the
drainage.
endoscopic.
It'll be
And
interesting to see that
primarily
because it's
surgical
probably going to
patients were
trigger
enrolled.
better. Sorry for the surgeons in the room.
Yeah, Santi from Rochester. Very, very informative and educational talks, all three of them. I don't have any questions, but just a comment. David, always very thought-provoking. You're always at the edge of the field, coming up with novel things. For the last 30 plus years, I've been watching. Very good. So I think I'm hoping with the new algorithm, the markers, angiopoietin 2, everything that you're planning to work, we will eventually come up with a predicting system. Unfortunately, with 500 publications of different markers, we don't have a good predicting system today in the first 24 to 48 hours as to who will go into that 5 to 10% severe acute pancreatitis or 20 to 25% MSAP and SAP together, which are the bad players. The remaining can be treated anywhere. Timbuktu or Hopkins doesn't make a difference. So I'm hoping that you will come up with, the main thing is the positive predictive value, good, more than 70, 75%. I'm hoping and banking on this thing. Thank you.
Thank you for the comment. And that's true. I think that looking at inflammatory markers are sort of a late thing and they're not readily available in the clinic. And so that's really what we're trying to do. We need tools that are available in rural America and Asia and Indonesia that anyone who has access to the internet can use whatever tools they have available in their clinic to get an assessment that's accurate and use that information to triage the patient and give them appropriate early treatment. So that's really, I think, what we need to do. It's that golden hour where they can't come to Pittsburgh or Rochester. They need treatment there.
Hi, David Vitale, Cincinnati Children's. Great talks. Thank you so much. I had a question about the infected pancreas necrosis. So that's something we encounter a lot in our pediatric patients, especially during the acute phase of necrosis with fevers. And we're trying to decide, is this infected necrosis or not? So I wondered if you could comment on, when do you go in and actually take a sample and try to get a culture from these? When's the right time to do that? If at all, do you risk introducing infection, and your comments on that?
That's a very good question. Obviously the classic sign is the gas bubbles, right, within the collection. And of course, we know Sears is very common, right? So everybody, you're worried, oh my God, am I missing an infection? Remember that the false negative rate is actually pretty high with aspiration. And so while that was touted as a technique kind of in the early 90s and kind of persisted for a while, it's largely been abandoned. And it's also been abandoned because in many instances, our interventional radiologists who often perform these aspirations, they want to leave a drain anyway. Anything they're going to poke, they want to leave a drain in because they're worried about introducing infection. So I think your clinical suspicion is really what should guide what you do next. And I think that's probably part of the reason why there's such a proliferation of using pancreas penetrating antibiotics. And then stepping up, of course, to percutaneous drain or doing that simultaneously in those patients who you really strongly suspect that there may be an infection.
Thank you.
Great, really interesting session. I have two questions. One is for Dr. Ballen, if he's on, and it is that often we're thinking about testing what we can, but in the light of for example, the morning session, there may be more opportunities to look at other aspects of imaging. And it just sort of dawned upon me that we've based much of our studies on necrosis as far as pancreas imaging, whereas bioenergetics is important. We heard about ATP, phosphorus, for example, of recent. And so I just wonder whether there might be additive value in looking at PET-CT in the evaluation of the severity of pancreatitis, short of the development of necrosis. That's one question. But the other is to sort of resolve the question between David and Vikash. David, you mentioned that the revised Atlanta classification was merely a historical value, but at least from the data that I just saw from Vikash, it sounds like organ failure that's persistent is really an important predictor of mortality. And so can we resolve the importance of the revised Atlanta classification?
So let's see if we can answer the first question. I think Dr. Ballen, did you understand the question?
Yes, the value of PET-CT in evaluation of necrotizing pancreatitis. Am I correct?
Yes.
Ooh, that would be a very expensive study to do in every patient who comes in hospital with an acute pancreatitis. And then again, what is the value of showing pancreatic necrosis in the first 6 hours, so to say, where there is no therapy available to counteract the development of necrosis? So when there is a medicine that counteracts the development of necrosis, then there will be a value to assess these patients very early in the course of the disease. Once we don't have any medicine available, there is no value of assessing parenchymal necrosis in the first 2 to 3 hours, in my opinion. I hope the clinicians in the audience and Vikash and David Whitcomb agree with me with that.
Thank you, Dr. Ballen.
I agree with you. To get back to the other second question. So it's not that the Atlanta criteria, revised Atlanta criteria, has no value. It has tremendous value in providing consensus definitions and some of those things. And for retrospective analysis, it's very useful. What I'm saying is that in the early part of acute pancreatitis, when you are in the evolving injury stage, you can't use late outcomes as an early marker of trajectory. And when you intervene with fluids, for example, early, you mask the underlying pathophysiology by maintaining blood pressure so it never gets below 90. Those types of things. And it leads to misclassifications of patients. Even with CT scan, if you get a CT scan within the first several hours of acute pancreatitis, it's normal because you're looking for edema. And it takes a while for that to occur. And so the point is that in the first 24 hours, you can't use late organ failure as a prognostic sign of organ failure. It's a measure that you've already failed, and that what we learned at Duke was sicker patients do worse. And so that holds here as well. If you're already in multi-organ failure, of course you're going to do worse than if you don't have any organ failure. And what we're trying to do is figure out what the mechanism is going from Sears to organ failure, and it appears to involve vascular decompensation with a loss of oncotic pressure, either from widespread proteolysis or from loss of the endothelial cell lining in a pathophysiologic or pathologic way. And that seems to be a very precise divider between those that just have Sears and get better quickly and those that go on to have multi-organ failure and end up, with all the complications we talked about. So from that aspect, the revised Atlanta criteria is not a good early classifier of patients.
Yeah, I think we can conclude that we are just on time. Thank you again for our presenters for the wonderful presentation, and also the audience for your questions and discussions. Thank you again, and hope to see you in the next session.
It's supposed to be our 9, but I didn't get here till 4.